Hi, I am Dr. Biresh, gynecologist and endoscopic surgeon. This is a short video about dysmorphic uterus and its management. Coming to the brief history, a 30-year-old woman with history of previous to mid-trimester miscarriage presented to us with the following HSG, which showed a narrow cavity with dysmorphic uterus. Three-dimensional transvaginal ultrasonography in coronal plane showed a T bar Y-shaped uterus according to CUME criteria. There was no other cause for miscarriage found in this patient. With this history, patient was subjected to lateral metroplasty for augmentation, and the patient also had a fundal dimpling for which a fundal metroplasty was also performed. With this diagnosis, we plan to perform an augmentation metroplasty. The initial laparoscopic view showed a broad fundus but with no other abnormality. Now we are entering the uterine cavity by vaginoscopic approach. Here we are at the level of cervical canal and trying to negotiate the internal loss. So that's the first view of the uterine cavity, which showed a narrow cavity, and also the osteas are widely placed and are not visible with scope placed at the level of internal os. So that's the narrow cavity, and there is some amount of fundal projection also, which shows more than 50% of the myometrial thickness. So there is some amount of septate component as well. So initially we plan to do a fundal metroplasty to release the septate component. So here you can see with gentle strokes of the scissors, keeping the line of cleavage between the two interosteal line. Small cuts are being made to release the fundal component. So the end point of my dissection here is decided by the visual clues, that is the septum most of the time being a fibrous component is pale, and the myometrium being a vascular is little pinkish in appearance. So this visual appearance is what guides me in deciding the end point of the septal resection. There you can see the fibers of myometrium being apparent, and also you can note the change in the color of the tissues. So the tissues which is pale white is becoming pinkish, so that shows that I have reached the myometrial component, and that marks my end of the fundal resection. So there you can see a lot of release has been done in the fundal region. Now I am planning to do a lateral metroplasty. So for this I am insinuating the non-articulating or the static jaw, keeping in line with the ostium, and then making small cuts millimeter by millimeter, and then progressing my hysteroscopy completely rather than just the scissors forwards. So repeatedly I am coming back and taking a panoramic view so as to see whether I am in line with the ostium. So that's a pretty much lateral metroplasty being done on the left side. Now I move on to the right side. So same thing, I keep the complex of the entire hysteroscopic operative sheath as one, and just with the scissors trying to move the entire system of the operative sheath rather than just moving the scissors. So that's the static jaw insinuating into the tissues, and then with the active jaw just making small cuts and then slightly progressing my entire hysteroscopic diagnostic operative sheath forwards with gentle cuts. So trying to remain in the line of the ostial and the internal os line. So that's the lateral metroplasty on the right side also being completed. So that's not the final surgery or the final completion. I will take a look back and try to see whether it is complete. So with the view from the internal os, I feel that the left side of the ostia is still not visualized. So I'm coming back and then again fashioning a little bit of the lateral projection. So I'm coming back and trying to see whether I'm in line with the ostia. So now the remaining endometrium shows the initial volume or the initial size of the cavity. Now with both fundal as well as the lateral metroplasty, you can see the augmentation of the cavity that has been achieved. So this surgery can be done even using a energy source with a Collins knife as well, but I would prefer to do it with cold scissors so as to not damage the endometrium or the myometrium. So there has been studies done showing that whether you do it with a resectoscope or with the cold scissors, the end results are the same. So here I am just making few more nicks. So this is the final panoramic view, and you can appreciate how much the augmentation or the increase in the volume of the cavity has been achieved. So again coming back, rechecking and then giving the final few cuts. Post-operatively, I have inserted number 8 Foley's with the 2 ml of distension to achieve separation of the raw surface and to prevent adhesion formation, and also have started estradiol for about a month. So that completes my surgery. So coming to a few information about this lesser known topic. So the T or Y-shaped dysmorphic uterus is a congenital uterine anomaly characterized by a narrow uterine cavity with a distinctive T or Y morphology. Historically, it was linked to in utero exposure to diethyl stilbestrol, but now it is increasingly recognized as a idiopathic condition as well. The prevalence is less known, but with a woman with a poor reproductive outcome, the incidence is about 1.5%. So in this presentation, I will be covering the diagnostic criteria, management and reproductive outcomes in the following few slides as well. Coming to the presentation, most of the time it is an asymptomatic, diagnosed incidentally on imaging. Symptomatic cases presents with recurrent first or second trimestral miscarriage, infertility or subfertility, or with preterm birth or cervical insufficiency. The imaging modality that can be used to diagnose this condition are 3-dimensional transvaginal ultrasonography with a coronal view. This is the best tool for evaluating uterine morphology because this allows us to measure the dimensions, angles, and the lateral wall thickness as well. Hysterosalpingography can also be used to visualize a T-shaped cavity, but it lacks soft tissue details and hence is not a preferred method. MRI is reserved for more complex cases of Mullerian anomaly, And as usual, direct visualization in hysteroscopy and concurrent surgical correction can be performed, but hysteroscopy is not the first tool for diagnosing dysmorphic uterus. Diagnosing of these anomalies are highly controversial due to absence of universally accepted diagnostic criteria and the debated clinical implications of their diagnosis and treatment. Defining a valid, reliable, and universally accepted diagnostic method with standardized criteria is the first step. For this reason, several authors published papers aiming to describe a strategy for the diagnosis of dysmorphic uterus, claiming their method is the most simplest and reliable method. Let's see all the diagnostic criteria that is been available in the literature to diagnose this dysmorphic uterus. First classification to include this was ASRM in 1988, which based on hysterosalpingography and the appearance of the cavity in the form of letter T, classified this as class 8 abnormality. So then came the etched in 2013, which classified this as U1A. Both this ASRM and etched did not include any measurement and were based on the visual appearance only. So this led to a lot of subjective variations. Then came the congenital uterine malformation expert committee in 2020 that included measurement of three measurements, and then to simplify this, in 2021 Paccio described a rule of 10, and in Alson 2024 modified this CUME criteria and gave his own diagnostic criteria. The etched classification classified dysmorphic uterus as class U1A, further into U1A, 1B and 1C depending on the lateral wall projection, the fundal dimpling and the ratio of the uterine corpus to the cervix. This does not have much of clinical importance because this did not include any measurements and is highly subjective. The first objective criteria was defined by this CUME criteria, that is Congenital Uterine Malformation Evaluation Committee, which measured three criteria. The first is the lateral indentation angle. This angle is calculated by drawing a line from the lateralmost indentation to the internal os as well as the tubal ostia and measuring the angle formed by this indentation. If the angle was less than 130 degrees, it was considered as positive. Next is the lateral indentation depth. A line is drawn from the ostia to the internal os and the projection in the lateral wall is measured. If the projection was more than 7 millimeters, it was considered a positive finding. And the third criteria is the T angle. Here a line is drawn joining the two interostium and another line joining from the ostia on the ipsilateral side to the lateralmost projection on the ipsilateral side, and then calculating the angle. If this angle was less than 40 degrees, then this was considered positive. So if all the three criteria are satisfied, then it is labeled as T-shaped. If only two criteria are satisfied, then it was classified as borderline T-shape. If none or only one criteria was satisfied, then it was called as a normal or arcuate uterus according to this CUME criteria. Then came this paper from Luis Alonso, the rule of 10. He tried to simplify this diagnosis by only including two measurements. He draw a line joining one ostia to the other ostia, and this is the interostial line, and at a distance of 10 millimeters from this interostial line, another transverse line in the uterine cavity was drawn and the measurements was taken. If the measurements of this cavity width was less than 10 millimeters, it was considered a T-shaped uterus. In case of normal uterus, it measured more than 10 millimeters. This is an interesting article published recently in March 2025. In this, the author compared the measurement used in three diagnostic criteria, that is by Exocostos, Ludwin CUME criteria and Alonso rule of 10, and he compared the measurements with that of hysteroscopy findings, which was considered gold standard, and he tried to analyze that which of the measurement parameters had highest correlation to hysteroscopic findings, and then he came up with three criteria, that is the lateral bulge, if it is more than 5 millimeters was considered significant, and the width of the uterine cavity at the level of interostia compared to that of the uterine cavity width at the level of isthmus. If that ratio was more than 5 was considered significant, and the ratio of the uterine cavity at the interostium to a distance at 10 millimeter, which was the same as rule of 10, and if any of the two measurements were positive, then it was considered more accurate for diagnosis of T-shaped uterus and correlated well with the hysteroscopic findings as well. So this shows that there is a lot of diagnostic dilemma in diagnosis of T or Y-shaped dysmorphic uterus. With this, we will move on to the next slide, discussing the management of dysmorphic uterus. The management depends on whether the patient is symptomatic, that is, if the patient has a T-shaped or Y-shaped dysmorphic uterus with a previous history of recurrent first or second trimester miscarriage, infertility or subfertility with an impaired embryo transfer, or previous history of preterm birth, cervical insufficiency, or is it totally asymptomatic in a woman seeking pregnancy and was incidentally diagnosed. There is no confusion in management of symptomatic women with dysmorphic uterus. The surgical intervention is very much warranted with hysteroscopic metroplasty, where lateral wall incisions are given to expand the uterine cavity. The evidences show that the pregnancy rate increases following surgery to up to 56% with surgery, and the live birth rate also increases to 60 to 70% post surgery, and the miscarriage rates also drop significantly to less than 20%. So the guidelines also says that women with symptomatic, that is with RPL or infertility, needs hysteroscopic metroplasty. The dilemma is in management of asymptomatic women, where a dysmorphic uterus is diagnosed incidentally and when they are seeking a fertility. What needs to be done? Let's see what the evidences say. So according to the evidences, there is no clear consensus. Unlike symptomatic women, there is no strong evidence to support routine metroplasty in asymptomatic women. So some T-shaped uterus women do conceive spontaneously without complication, although there is higher risk of miscarriage and preterm birth when compared to normal uteri, but that doesn't warrant a surgery. So this is supported by a study from Gribbis et al., which showed that not all T-shaped uterus behave the same, and some may have near normal pregnancy outcome without posing any significant abnormality. Suppose you consider metroplasty in these asymptomatic women. Let's see what are the potential benefits and the limitation. So coming to the surgery is not very morbid, easy to perform, and gives good anatomical results as well. And when you incidentally take this woman for hysteroscopy or a diagnostic hysterolab for some other reason, probably for evaluation infertility and then for a polypectomy or any other cause, then correcting this will reduce the miscarriage rate and achieve a post-pregnancy live birth rate of about 60 to 70%. What is the limitation? There are no RCTs comparing expectant versus surgical management in asymptomatic women, and also surgery carries a slight risk of uterine perforation, adhesion, and rarely Asherman syndrome. So the evidences, that is SRSG and ASRM guidance, does not recommend routine surgery for incidentally detected dysmorphic uterus. Consider metroplasty only if severely distorted cavity, prior failed IVF with good embryos, or patient preference after a risk-benefit discussion. So what needs to be done if a woman with a dysmorphic uterus conceives spontaneously and she is carrying a pregnancy? The serial cervical length assessment needs to be done because they are at risk of cervical insufficiency. Again, cervical incerclage routinely is again controversial. High risk obstetric care because they are at risk of preterm birth. Regarding the route of delivery, there is no route recommended guidelines to say whether cesarean section needs to be done in T-shaped or dysmorphic uterus, or post-surgery whether these women has to be subjected to cesarean section. So the cesarean section is limited only for obstetrical indication in these women. If I have to summarize the clinical management, if you incidentally find a T-shaped uterus with no infertility or recurrent pregnancy loss, just expected management with pre-conception counseling needs to be done. If severe T-shaped uterus, then can consider metroplasty with a shared decision making. Prior miscarriage or IVF definitely needs a metroplasty. If they achieve a pregnancy before treatment or untreated, then high risk monitoring for cervical length, encerclage, and preterm prevention can be considered. To conclude, a T-shaped uterus poses significant reproductive challenges, but outcome can be optimized through accurate diagnosis using 3D imaging and hysteroscopic metroplasty. Collaborative care involving gynecologist, radiologist, and fertility specialist is essential. Women with recurrent pregnancy loss or infertility should seek a specialized evaluation to tailor management and improve pregnancy outcomes. Asymptomatic women with a T-shaped uterus do not universally require surgery, but severity assessment is crucial. Shared decision making should weigh the potential benefits of metroplasty with the risk of surgery. Preconceptional counseling and high risk prenatal care are essential for optimizing outcome. While evidence is limited, individualized care rather than one size fits all approach is key in managing incidentally detected T shaped uteri. These are the references for my presentation, and if needed, one can go through if further information is required. With this, I conclude my talk on this lesser known controversial topic. Thank you all for watching this video. Hope this was informative.